Hey everyone, we have a packed agenda, so we'll get started in just a couple of minutes as people are coming in from the waiting room. Okay, well, let's go ahead and get started. Hi everyone, my name is Sarah Briley. I am the program manager for COAIM SUD with CPCQC, and this will be our May Learning Collaborative call. And as I said, we have a packed agenda, a lot to cover today. So we will get started with Dr. Lisa Becker sharing a patient story.
Hello. Hi everybody. So yeah, we had a joyful patient outcome recently. 12 weeks ago, we had a patient who was 29 weeks pregnant flown to us from a sister facility. Mom was flown to us because she had respiratory failure, both from an accidental overdose and from accompanying pneumonia. She spent 3 days in our intensive care unit on a ventilator, and then 10 more days in our facility recovering from her ailments. Since we have had such awesome support from Moms Plus, we were actually able to speak to her about using medically assisted treatment in her recovery, and she was very open to that. She came back to us now 12 weeks later and had her baby at our facility. And I can't tell you how much joy it brought me to walk into her room and see her. So we are very grateful to everyone who has helped us to put in some of the infrastructure. We are definitely working on a lot of things in our facility, but we are really happy for this family.
That's wonderful. Thank you so much for sharing the story. Any really quick questions for Dr. Becker?
Did baby get to go home with her?
Yep. And I should say by home, she is in a recovery center, and she's been living there since she left our hospital. So our case management did a great job helping her to get information.
That's great. Thank you.
You're welcome.
I will now pass it to Gretchen to talk about some of the Q1 data.
Hi, everyone. It's great to see so many familiar faces. For those who don't know me, my name is Gretchen Scholes. I'm the data analyst here at CPCQC. Thank you to everyone who submitted for Q1 2024. This is just a quick snapshot. I know we can do better Q2. And for those of you who still have that Q1 data, please, there is no deadline in terms of getting it into us. We would love to see it. And that way we can give you some really helpful feedback in terms of your QI and how you all are doing in your hospitals. We had 25% of hospitals submit clinical care checklists. That's the patient level form there. And then 29% of hospitals submit hospital level data on screenings about patients. Next slide, please. Overall screening rates for those who submitted were really, really great. There was an increase in SUD screening of 14% since the last quarter, so that's wonderful. And then also a 2% increase in screening for depression. These are just some snapshots that you can find. And for those of you who have looked at your data dashboards, you'll be able to see this is for the cohort overall, but you'll be able to see your data as well reflected on your own personal hospital data dashboard. Next slide, please. In terms of naloxone care, we saw some really great increasing in Q1 from the previous year, even a 30% or 13% increase in counseling, a 15% increase in prescribing of naloxone, and a 16% increase in distribution of naloxone. So bravo, wonderful, wonderful work there on the naloxone care. Next slide. And in terms of MOUD care, it remained relatively steady with MOUD care, which is great. We like to see steady or increasing here. 10 patients screened positive for opioid use of the data that was submitted for Q1. 7 received counseling on MOUD care, 4 received MOUD, and then 6 were referred out to MOUD care. For those of you, that's sort of a quick snapshot because we don't have too much time to go over data, but I just wanted to say for those who have access or are confused in terms of accessing their data dashboards, please feel free to reach out to me. I'm happy to walk you through that process and get you set up if you don't already have access. I will go ahead and drop my email in the chat. If you have any questions, please don't hesitate to reach out.
Thank you, Gretchen. Really quickly, we will also, in the follow-up email for this call, be sending out a survey to see how we can better support you with data collection and submission. So please fill that out. We want to give you the best data possible, and we can only do that if we receive that data from you. So it's very important to this work that we are doing. So please fill that survey out that will come to you with this recording. I will next pass it over to Angela.
Hi, everyone. Thanks for having me today. For those of you I have not met yet, my name is Angela Swafford. I am a social worker with the Moms Plus initiative. I'm going to talk about care transitions and warm handoffs today, and then I'm going to pass it over to some of my favorite people that I work with. Go to the next slide. All right, so we're gonna talk about, first of all, what the different community treatment options are and levels of care, different care team roles within the hospital setting, navigating those treatment options and how to build solid referral networks, facilitating warm handoff, and then common barriers we see in care transitions before moving over to talking about peer support services. Go to the next slide. Perfect. Thank you. Okay, so some of this terminology is probably new for all of you, so just wanted to start off with the different levels of care that are available. So the first and kind of most restrictive that you've probably heard of when you think of rehab for substance use disorder treatment, that's usually in reference to intensive residential treatment, sometimes called IRT. Residential is a live-in treatment program that typically runs for 30 to 60 days, very payer dependent, unless someone has a lot of financial means and can pay independently. Sometimes they go longer. A lot of those programs offer transitional living options, so a patient can stay there, but once they've completed the residential treatment, they can stay an additional 30 days if they still need that structure and support. These are really highly structured environments, so you leave your life, you go to a residential facility, and you live there for usually 1 to 3 months. So it is not for everyone. I've heard Raquel say, residential is really for the privileged. It's not easy, especially if you're a new mom, have other kids at home. It's not easy to just drop everything and go to residential, but for some people, it's really necessary if they can make it work. Access can be challenging. There are wait lists, different insurance requirements. There's some really great ones in Metro Denver that allow Some of them allow children to remain with the mother during treatment, which is great. Some, due to the type of building it is, allow up to 15 months. If there's a old Victorian building that once a baby starts crawling, it gets a little dangerous. There might be those limitations. There's some that allow older children as well. And we've got a hyperlink on the slide deck, but all of our Moms Plus vetted partners, there's plenty of providers in the community, but the ones that we're closely partnering with that prioritize this population, those are all listed on our website as well. There's also sober living. Sober living is a housing environment. So it's alcohol and substance-free facilities where you're basically getting room and board with some programming, but it's not an intense, structured medical type of program. There's structured living conditions for those seeking recovery. It can be super helpful for those experiencing housing insecurity or those who maybe have roommates or other folks that they live with that do use substances when they're trying to seek their own recovery. It typically requires a payment or a fee to cover that room and board. Sometimes meals are covered, sometimes they're not, depending on the program, but some have grant or MSO funding that's available for indigent patients as well, so there are some options there. Go to the next slide. Thank you. Okay, I'm guessing a lot of you have probably heard the acronym OTP. That is an opioid treatment program. So if you haven't heard of that, if you're familiar with ARTS, Behavioral Health Group, or BHG, Denver Recovery Group, Magnolia, those are some of the common OTPs that we have in the Metro Denver region. So these are your methadone clinics that you can think of. They do other services as well. They're all going to provide buprenorphine, usually naltrexone, and some other options. But these are a little bit more restrictive because they are federally regulated. So OTPs get federal funding, and as a result of that, they do require that you have a valid ID in order to be seen. I believe Denver Health's OTP maybe has an exception to that because they do see uninsured, undocumented patients, but that can be a barrier for some patients. If a patient is eligible for an ID but just doesn't have them, they usually have case management and can absolutely help the patient get an ID in order to continue being seen, and they will definitely help with that. But if someone is not ID eligible, it may be a barrier for them, so it's best to just call and ask, but that usually is one limitation with OTPs. So any patient that is being started on methadone, when they are discharged or for any follow-up, they need to be connected with a local OTP. And in some rural areas, there's some mobile methadone vans that go out too. So the state of Colorado is getting a little more creative, which is great to see. But OTPs do require for methadone that you show up daily to a clinic. Usually they open around 5 a.m. and close by 11 a.m. for patients. You may think of, like, back in the old days, construction workers lining up before working for the day. That's why their hours are so early. But you usually get dosed every day. And I think it takes up to 2 years in treatment with an OTP before you are allowed to get up to a 28-day supply of methadone that you can take home. So there are options. It just takes a long time. All right, and then the next level is OBOT, or office-based opioid treatment. This is usually integrated substance use care in a setting like primary care or sometimes OBs. I know Stride has an OB provider that has started providing buprenorphine, which is great. They're one of our partners as well. They usually offer some comprehensive services, so some behavioral health programming, whether it's individual counseling, group counseling, along with that medication provider and your primary care, specialty care, whatever that is. They are very low barrier to access. Most primary care offices do not require that you have a valid ID to be seen. They can work around that. And if you have like a hospital face sheet that the patient can bring, or their hospital band, library card, anything that kind of says their name, you're usually fine there. And there are often telehealth options as well. So those usually start with weekly or bi-weekly appointments, just depends on the program, what their structure is, but they're usually flexible. And once a patient's been seen a couple times, they'll likely transition to being seen once a month, maybe with some telehealth options there. We can go to the next slide. Thank you. Okay. And then two other options. So you may have heard the acronym IOP. That stands for Intensive Outpatient Programs. They're very common in behavioral health. It is one of the highest levels of outpatient behavioral health care you can get before you go to something like a partial hospitalization. IOPs are not always substance use focused, but there are, a good amount of substance use disorder IOPs specifically. They are very structured group therapy sessions. So typically the model is 3 days a week, 3-hour groups, plus typically 1 hour of individual therapy a week. So there's different times. Sometimes there's morning one and evening ones. 6 to 9 p.m., which can be tough with a baby, but a lot of them are virtual as well, just to increase access. But looking about 9 to 10 hours a week for someone that doesn't quite need to go inpatient, but maybe needs a little more structure. A lot of them have a psychiatrist available, and they have to have that. So some of them are trained in addiction meds, some aren't, but should be able to prescribe medications as well. So there is that time commitment, but there's virtual options as well. And then I'm sure you've all heard of just traditional outpatient. So you can think of things like counseling only approaches without medications, things like individual therapy and group therapy, with or without meds, but traditional outpatient is typically just those straight therapy options. There's also addiction medicine clinics where you can see an addiction med provider. Perfect. I would be remiss if I didn't mention harm reduction agencies. So I'm sure you're all very familiar with harm reduction as a philosophy and approach, but there are these brick and mortar harm reduction sites that offer anonymous services. So if you've heard of like safe needle exchanges, syringe access programs, that's what these are. So like up in the northern area, there's the Works is a big one over there. There's the Harm Reduction Action Center in Denver. Lots of options there. They're usually partnering with your local county public health department. Their whole focus is public health and harm reduction for individuals who use substances or engage in other risky behaviors. So they offer needle exchanges and injection supplies. Most provide fentanyl and xylazine test strips, which is great. There's usually free naloxone access. They do a lot of STI testing, including HIV and Hep C. And then they all have case management and supportive counseling and ways to refer. So if someone's been going there for a while and decides they're ready for treatment, they will absolutely provide a referral, tell them an ED they can go to if they want to get started on Suboxone and things like that. So those are good to be aware of as well. And we do have them mapped out on our map on the Moms Plus website as well. Okay, so I'm going to do a quick poll. I know that was a lot of info and probably some new terms for a lot of you. How many of you feel lost or overwhelmed when you have a patient that is interested in treatment, when you're thinking about where you should send them and where to go next? If you could raise your hand using the reactions. And some hands. Yeah, very common, what we expected. Absolutely. Yeah, it can be really, really overwhelming. And before I started doing this work back in 2018, I had no clue where to start. I was kind of given 1 or 2 partners when I helped set up our program at Anschutz in the ED back in the day. Took a lot of work to figure out who they are, what they do. It's a lot of work, a lot of meetings on the Moms Plus side. And we've tried to do a lot of that work, which is on our website. Happy to connect folks as well, but it can be really overwhelming with where to start. So if we go to the next slide, we're going to talk about who should do what when you're interacting with patients within your hospitals or in an outpatient setting. Okay, so first of all, we're going to hear from Raquel and Megan shortly, but first thing I always want to mention is peer support services, which you'll hear more about shortly. Peer services are really the best starting point for anyone in a hospital or healthcare environment, and a service that you should offer to patients early, regardless of a patient's motivation for treatment. Peers are very skilled in a lot of different areas, but particularly motivational interviewing, providing that non-judgmental human connection, navigating community resources. They also know which resources and treatment centers have better reputations than others. And they really bring hope to patients in a way that often usually healthcare providers cannot. Any care team member can offer peers. It's best to offer it earlier during a patient's stay and or offer it often. You don't want to nag a patient, but sometimes explaining it different ways can help, and they can really help navigate all of this throughout an admission as well. So the providers are super pivotal here. Big part of their role is offering medications for comfort, so treating withdrawal, whether that's comfort medications or initiating treatment if a patient is interested during the hospitalization or routine visits. Reducing those barriers to care. So trying to focus less on, shipping people off. Oh, you got to go here to get care for this. We don't treat that here. Starting care with a no wrong door approach with the patient where they're at, wherever they present in your hospital. Another great thing providers can do is share success stories that you've had with other patients. If you've had good experiences helping get patients started on treatment, sharing things like, how you've seen someone's withdrawal be really mitigated within maybe it was 20 minutes of starting Suboxone or buprenorphine during an admission, explaining how it works, explaining, if you've seen someone come back for follow-up after getting started on treatment during an inpatient hospitalization, how that mom is doing. Sharing those stories really go a long way and help show that you're championing that as well. It also just normalizes treatment and helps mitigate some of that stigma. And then providers should definitely consult others. So getting peers involved, social workers, case managers, having team discussions with the patient as much as possible to engage in those conversations around available options for support. And sometimes talking about together what medications you're going to start, if any, and then where someone can go for follow-up is helpful as well. All right, and then nurses. So nurses can play a lot of different roles in a hospital setting, but one of the biggest things is to keep an eye out for signs of withdrawal, make sure that's communicated to the provider, as well as any interest the patient may express in treatment. If the patient is considering medications, also sharing success stories you've seen with other patients who started treatment during the hospitalization. I think with Suboxone, it can be a little tricky if you're not doing a microinduction. Having a patient have to go into full withdrawal can be kind of a tough sell sometimes, but being able to say, once we get your right dose of Suboxone, if you're taking the sublingual films, really within 15 to 20 minutes, I've seen a lot of people have immediate relief within that time frame. So if you can just hang on a little bit more, I know this is awful. We can see if this medication helps you, and if it does, it should be pretty quick. Things like that, just setting expectations for the experience help, and also sharing those success stories from what you've seen with other patients. Making sure we're administering medications timely, both treatment and comfort medications. And once those medications are ordered and initiated, making sure you're doing things like the cows every hour if it's ordered that way, and dosing appropriately so we can help treat that withdrawal as soon as possible. And then again, just consulting others, so peers, social workers, case managers, to engage in those conversations as well. And then the role I put social workers, case managers, and patient navigators, care coordinators kind of in the same bucket. They do different things, but oftentimes this is the group that is tasked with setting up follow-up. So along with engaging in those conversations with the patient and the rest of the care team, meeting with the patient individually to really assess those needs and social factors, which I'll talk about in an upcoming slide. In my opinion, that is personally the biggest factor in where a patient's going to be most successful is their social factors and where they're going to be able to attend treatment that works for their lifestyle, their unique needs, what they've got access to. If a patient's interested in treatment, working with them on identifying the best treatment provider for their individual needs and based on their choice. We will talk about patient choice in a minute, but we should not be dictating where a patient has to follow up. It may be the case if you're in a very rural area and there's only one provider, but there's sometimes telehealth options as well. But working with the patient to identify where they really want to go. And then super important, as much as possible, scheduling an intake appointment and providing a warm handoff, ensuring the patient has a prescription for medications to last them through that appointment. So things happen. Sometimes an appointment gets canceled by a day. If it's something like Suboxone, where you can get a bridge prescription from the provider, asking your providers to be liberal. So if the appointment's in 3 days, can we get a week prescription? Things happen, bus is late, miss the appointment, you can't get in for another couple of days. So trying to give the patient a prescription that they can fill and take home before they establish with care with a couple days buffer is super helpful. Not possible for methadone. We can get a 3-day script for that. But for things like Bup or Suboxone, definitely want to be liberal with that bridge prescription. And then be a champion and advocate. So again, just sharing success stories. I think that goes a long way when we talk about how we've seen other patients do, if we've seen them come back to our care, how well they're doing, how much this helped them. And then again, offering peer support, like, hey, I know someone, I know a mama in recovery who would love to come and talk to you about the different options. I know this is overwhelming. Would you be willing to meet with her? Which we'll talk about with the peer piece in just a moment. Go to the next slide. Thank you. So where do we start? Can be overwhelming. This is a lot. But again, just want to reiterate the importance of patient choice. So really thinking through, where is the patient going to have the fewest barriers? Is my patient experiencing housing insecurity and maybe couch surfing with friends and they don't have access to a vehicle? I'm probably not going to start you on methadone and make you show up to an OTP every day before 11 a.m. Unless you truly need methadone. That's a lot of barriers. That's a lot of a time commitment, especially for a new mom. And sometimes methadone is the best option and people can make that work. But if someone's staying at a shelter, doesn't have a car, that can be really, really difficult. I'm always impressed when patients take Medicaid transportation to OTPs daily, because there's a lot of challenges with Medicaid transportation. It's a great service, but if any of you are ever involved in setting that up, they can be they have very large windows with when they'll arrive. I was doing a tour of one once, and a patient showed up right after they'd closed, and it was lunch break, and it was his Medicaid transportation that was late, and they were like, he can come in and get his dose, of course. So just thinking through those pieces, you don't want to send a patient somewhere because it's your partner, but they're not going to be successful. Where is the patient willing to go? Do they have a friend that got started on treatment at Front Range Clinic, for example, that's had a good experience? Word of mouth goes a long way. If there's a provider or a clinic that someone really trusts that they've heard good things about, that would be a great option. Even if it's not a service you're familiar with, you can always call and get more information, as well as offering your own partners. And then with treatment initiated already. So if we started someone on methadone is tough to switch over to buprenorphine because it's so long acting. They are going to need to go into withdrawal unless you're doing that micro-induction. But Suboxone to methadone is pretty easy. But if someone started on methadone within the hospital, you are going to want to connect them to an OTP. But if they're started on Bup or naltrexone, or they're not started on medications, but they're interested in different options, it's good to know who can do what. There are tools out there. So the ASAM criteria, which is the American Society of Addiction Medicine, there's the different levels of care that are recommended based on different dimensions. There's also for opioids, the treatment needs questionnaire, the TNQ, which I have personally used a lot back in the ED. These are really tools that are meant to guide the level of care a patient is best suited for based on their level of use disorder. But I've always considered these as recommendations. Someone could have a severe use disorder and the TNQ may tell you they really need residential treatment. But if it's a new mom, they're a single mom, they've got kids at home, they don't have support, that's not going to be feasible for them. We need to come up with other options that can meet her needs. So really looking at those social factors and logistics, there's a huge opportunity cost that goes along with any kind of treatment. So if you think about, I'm a new mom, I've got to go to an intake appointment, it's on a Monday. Let's say I'm not working, maybe I have maternity leave if I have that luxury. I gotta, find a sitter, pay for a sitter for my kids. I have to take the bus, pay for the bus to go to that appointment. Taking time out of my day, it's costing me money to get there. That's an opportunity cost with going to that appointment. So those are good things to keep in mind. That it's going to cost patients money depending on some factors like that. And is that something they can afford? If the bus is going to be a few dollars and they've got to go a few times a week potentially, is that reasonable? So other things to keep in mind is proximity. So someone can be unhoused, but maybe they live within a mile of a local OTP, and that would be realistic for them. So what centers are they close to? Do they have access to transportation? Do they have access to childcare? Are they going to need to take time off of work? And if so, what would that look like? And then the insurance and funding access, I will say, with substance use disorder, Medicaid and patients that are uninsured are often the easiest to plug in places. Medicaid has really decent reimbursements. And patients that are uninsured, there's typically grant funding and MSO funding for that as well. Go to the next slide. Just a couple more slides. Are we doing okay on time, Sarah? Okay. Just want to make sure I'm not cutting anyone off later. So building referral networks, again, on our website, which I saw, I think Rachel posted in the chat, we have a whole vetted list of Moms Plus partners. There are plenty of other providers that do great care that we're happy to reach out to as well. This is just a group that we have vetted that have been very engaged. Most of them are special connections providers and prioritize the perinatal population. But it's really important to have a relationship between the hospital and those community providers. You don't have to for everything. Like I was saying, if a patient really wants to establish care somewhere that they've heard about and you don't know that provider, you don't have to. You can always call and get more info, but it is great if you have that relationship. And you can help with warm handoffs and coordinating that care, which I think I have another slide about warm handoffs. But being able to say, hey, we work really closely with Front Range Clinic and with Denver Recovery Group. They're both really close to where you live. Here's the different options they both provide. Here's what you can expect. Do either of those sound like a good option to you? Have you heard of either of them? And just decreasing siloing and this feeling I've heard Raquel mention of being shipped off for treatment. So you're in a hospital, you're in withdrawal, but sometimes patients are met with, oh, we don't do that here. We don't treat that here. You have to go to this other place where that's what they do. Being able to say, this is our partner, or this is a part of our system that has this addiction medicine clinic, just coordinating that care and having that integrated setting goes really far. And then also having human connections. So maybe you know Dr. Coyle at Arts, who is going to see your patient you just scheduled an appointment for, being able to say, you're going to see my friend Tyler. He'll say he's Dr. Coyle. You can call him Tyler. He's really great. He's helped a ton of my patients. I have gotten great feedback from patients that have returned that I've seen saying they really like him. He's really looking forward to seeing you. Can go a long way. If you have that relationship, you might not always, but being able to share what you know about them. So getting to know community treatment providers, understanding their intake process is huge too. Intakes at an OTP sometimes take 3-4 hours. There's a lot of paperwork. You're going to meet with the medication provider. You're going to meet with a counselor. You might meet with a separate caseworker. So getting to know their intake process. So you're not just telling the patient, hey, you have an intake at 8 a.m. on Monday, where they're maybe getting a sitter for 2 hours, thinking it's a 30 or 60-minute appointment. But in reality, they're going to be there till noon. Those things are really important to communicate. And oftentimes, if we've done a thorough intake and done a great job with the warm handoff and faxing over records, you can cut down that time as well. And then just understanding the services the different providers offer, including what medications they offer. And then just another plug there, that is a hyperlink if these slides are sent out. But I know Rachel put it in the chat too. But our community partner list, which I reach out quarterly to all those partners to make sure I'm keeping that updated. Here's the warm handoff piece. So I'm guessing some of you have not heard of a warm handoff before. When we talk about a warm handoff, we're really talking about not just faxing a packet, not just making an appointment, but really communicating with who you're referring to, a little bit of this patient's story, whatever's appropriate. Please don't go into their whole trauma history if the patient has shared that with you. But saying things like, hey, I'm referring Susie. She's been working really hard to meet the needs of herself and her children the last few years. She previously tried buprenorphine that she got on the street from a friend, but she experienced precipitated withdrawal. She's interested in starting methadone at this time. We started methadone during this birthing hospitalization at maybe 40 milligrams with whatever results. So maybe she had a great response to it. She feels very clear-headed, like she's able to function, and she's really excited. anything like that that you can communicate really goes a long way. And one thing I would definitely recommend is less siloing and talking about patients behind our backs. There's a lot of like, okay, let me go make a call, which creates a lot of fear and distrust. If you are in a spot where you have a mobile phone, a lot of us have those actual mobile phones in hospitals. I think a lot of folks are phasing out pagers. But if you can call in the room with the patient, be like, hey, I want to schedule an intake. We just, per our discussion, we decided DRG is best for you. Let's call and schedule an intake. Can I make that call with you in the room right now? Which may be tough if it's an OTP, depending on if it's later in the afternoon. But making that call with the patient and being like, is it okay if I share a little bit about your story? That can really help. And you can also offer to hand the phone to the patient. If they want to provide their own information, their name, date of birth, a little bit of their history, that's a great way to approach it too. Best thing you can do is please make sure your patient has an intake scheduled prior to discharge. Oftentimes we're very sparse with resources, very busy. We have a ton of other patients to see before they discharge at the end of the day. But handing a patient a piece of paper, they're probably not going to make phone calls. And if they do, some of the numbers are probably outdated unless you have an intern, maybe updating those lists pretty routinely. It's just setting patients up for a lot of additional barriers and a lot of work on their end. To have to go through that, if they are motivated, that can be really defeating if they make a couple calls and no one answers. So as much as possible, trying to get them an intake scheduled before they discharge so they can leave knowing they have that appointment in hand. And then with the patient's consent, you want to send over a referral packet. So you can do a great warm handoff, but if they don't have any records, they're going to have to repeat some of that information. We have the luxury of having things like H&Ps, relevant labs in a hospital setting. So sending over a referral packet with the patient's consent for the face sheet, what treatment was started, that H&P, any relevant labs, and anything you've done on the social work or care management side with your assessment that goes through that as well. Go to the next slide. Thank you, Sarah. And then, a warm handoff on the side of the patient. You really want to communicate expectations back to the patient. So how long are they needing to expect for the intake appointment? Is it 30 minutes? Is it 4 hours? Those are very different things to plan for. Again, faxing and emailing overall relevant information really cuts down on the amount of time that the patient has to spend at that appointment. So getting to know your local treatment centers, where you're going to send most of your patients, and what would be helpful on their end is super helpful. If a patient is pursuing IRT or residential that has a wait list, what do they need to do? Some of those programs will actually call a patient weekly to see if they're still engaged and interested while they're on the wait list. Some of them really encourage patients to call every day and check their status on the wait list, which may or may not be feasible for some patients. But if they're really interested in going to a program like New Directions for Families, partnering with them to know, should they call every day? Are you going to call them? What's that expectation? And letting the patient know what to be on the lookout for. And then sharing any personal information you have about a treatment provider or clinic. So I used Kaylin as an example here, but saying things like, hey, you're going to see Dr. Klee in our outpatient clinic. She works with moms with substance use and has helped so many patients. We've referred to her for treatment. She knows you're on her schedule for Thursday and she's really looking forward to meeting you. Do you have any questions about Dr. Klee or what to expect for that appointment? Just kind of normalizing the human aspect. I know sometimes for Kellen team, we'll get Kaylin on FaceTime if there's patients that are a little weary about providers. So having that relationship, getting to know your treatment providers too, goes a long way, and being able to kind of humanize the providers too. The medical field and healthcare providers come with a lot of stigma for patients, which we're all doing a lot of work on, but it can really help to humanize them and say things like that. Okay, I wanted to mostly wrap up with just a patient example. I want you all to just put yourself in this patient's shoes. And I'm sorry it's wordy. I wanted it to be on the slides for future reference, because this is something I've definitely seen happen. And it breaks my heart whenever I run into patients that had returned to the ED after a situation like this. So just put yourself in this situation for a minute. So imagine you recently gave birth and you have an opioid use disorder. The hospital you delivered at started you on buprenorphine or Suboxone and referred you to an outpatient clinic that has walk-in intake availabilities on Mondays. They provided you with a bridge prescription that lasts until Monday's appointment. And you coordinate getting childcare, you take time off of work or whatever other obligations you have, and you spend a few dollars on your limited income paying for the bus to get to the clinic during the time frame the hospital staff told you to arrive on Monday. The bus is running late, but you're relieved because you still get there during the time frame specified for intake hours. When you arrive, you're told walk-in hours are first come, first served, and likely already full for the day. The clinic also doesn't have any information about you and had no idea you were coming in for an intake, even though it's walk-in. No one coordinated that for you. They ask if you can come in earlier next week on Monday for an intake, and they're unable to provide you with medications until you see their provider next week. You took your last Suboxone film this morning, and you're going to go into withdrawal later today. How would you feel? I don't know if people want to come off mute or drop in the chat. How do you think that would feel if that was you? You've got a new baby, you've been on Suboxone for a few days, and you're about to go into withdrawal when you did everything the hospital told you to do. Yeah, defeated. It's a great way to describe it. Devastated, absolutely. Overwhelmed, yep. And imagine being a new mom too, or you have other kids and you have a new baby at home. Panic, alone, overwhelmed, absolutely. Panic, yes, lots of panic. You've started treatment for a few days, you know how much it helps you, and now you've just been denied treatment. This is really why it's so important. Freaking out, yes, Raquel, absolutely. This is why it's so important to do our due diligence and make sure we're sending patients where they're going to be successful, coordinating that warm handoff. I've had patients that, an OTP we partnered with texted me and said, hey, they didn't show up. It's 10 o'clock. We're open till 11. They were scheduled at 7 a.m. I called the guy. He was like, oh, I slept in too late. I can't make it now. And I was able to text and coordinate, and they were willing to see him at 11:55 when he got there, which is great. So having that personal relationship, it's not feasible for everyone, especially once the patient's discharged, but having that personal relationship and being able to coordinate the patient's care goes so far and really shows to our patients that we care and we're invested in them getting that treatment. Yep, Raquel said already thinking about who I'm going to call so I don't get sick. If I'm sick, I can't care for my baby. Absolutely. Yep. You're probably going to be looking for opioids to treat your own withdrawal so that you can be a functioning mother. Absolutely. That is super common. So to wrap up here, just common barriers in care transitions. We've kind of talked about these, but not knowing which agencies provide which services. So sending a patient to an outpatient clinic that offers therapy for substance use disorder, but doesn't have medication access is not going to be very helpful for a patient who's interested in medications. They would need to go somewhere else to get those meds. Many clinics offer both meds and supportive services. So just being aware of who can do what. Again, all of our partners are on our website. Lacking that coordinated referral, so sending patients to a clinic or agency without coordinating a referral really sets them up for that siloed care and increased barriers. Even if a patient shows up on time for their appointment and they're able to be seen, if the clinic is saying, oh, I don't have any information about you, and they're saying, oh, UC Health sent me from this hospital, that's not a great feeling for the patient either. And for the clinic, that creates more work for them. Being mindful of still sending that referral and facilitating a handoff for patients with walk-in intakes is huge too. Referring patients to programs with too many barriers for their needs. If a patient is unhoused and does not have transportation, unless methadone is truly the only option for them, or they live super close to a local OTP, please don't send them there if that's the only place that you're trying to send them for methadone. If they don't need methadone, let's look at maybe bupe or some other options for them. And then not offering patient choice. Just because we have partners and maybe we have an easy referral process, a lot of OTPs, they have, or I think all OTPs are required to have a 24/7 phone line you can call for things like verifying a dose in the middle of the night. Most of them will actually let you as healthcare providers text those lines to schedule an appointment. So even if it's the middle of the night, you can text. I know like Denver Recovery Group, for example, has a 15-minute response time. So you can get that. So even if it's a really easy referral for you, if a patient has heard great things about Front Range and they really want to go there, we should call and we should try to get them plugged in there. Having, street cred, word of mouth from knowing someone that goes there and got great care, that's, a plus in the patient's favor as well. And that they've heard good things about a program. So that can be more incentivizing to go and initiate treatment as well, which can be really scary. All right. And then Just key takeaways from all of this before I turn it over to Raquel is just get to know your referral network. That human connection really goes a long way. Offering peers early and often. If a patient didn't accept, don't be pushy, but different people can mention it, especially if you offered it when a patient's in withdrawal. They're probably not able to absorb much information at that point. If you've started them on treatment or their withdrawal has been treated, whether it's comfort meds, opioids, whatever you're treating that with, being able to have that conversation again, see if it's something the patient's interested in. Assessing where the patient's going to have the least barriers to care. We really want to set patients up for success and remove as many of those barriers as possible. Providing that warm handoff and communicating expectations to the patient, and then offering and honoring patient choice with that shared decision making. That's going to be key. And with that, I will turn it over to Raquel and Megan.
Actually, I think you're just getting me today. I think Megan took some time off this morning. Hello, everyone. My name is Raquel Garcia. First and foremost, I am a woman in long-term recovery and a mama. For me, that means I have not had a drink or misused a prescription in 14 years. I'm also a peer recovery coach. I like to say I'm a peer recovery evangelist. I'm someone who really believes in the power of peer. It has saved my life and in turn is saving others. Let me tell you a little bit about peer and what peer support is. We combine our lived experience along with our education to empower clients to move them forward from recovery to discovery. We're accessible via text message and phone during times when most people are not. We are not a therapist. We're not here for just the 1 hour session on Thursdays at 2. You might have your therapy session on Thursdays at 2, but something happens on Tuesday at 4 and you need support. That's when we show up. We also show up on Wednesday at 1 and at Saturday at 9. So we get to fill in all of those gaps when people don't have time. And we can be there on the holidays. We take a non-biased approach to recovery and substance use disorders. We don't really care what pathway of recovery you choose. There's all kinds of ways that you can choose to recover. I was a 12-step person. My husband raised chickens for the first year and a half of his recovery to keep him sober. So I always like to bring that as an example of the different ways people recover. And my husband was a Crip gang member, so that's another added feature to the chicken raising. We bridge the gap between the client and the family for recovery resources. You know, we are that resource broker. We used to be hustlers in a very different way, and now we use those same assets and skills that we used to survive, to build thriving for those that we work with. We give life purpose, so we figure out not just staying sober. Sober feels like white knuckling and just trying not to do the thing. And we really like to bring awareness to life purpose and do this post-recovery growth where you're really building into yourself beyond recovery. We do help to reduce setbacks, relapse, repeat behaviors. That's actually something we talk about. And if it shows up, we get to work with people around that. We advocate on behalf of the client, especially when it's coming into the labor and delivery spaces. I'll talk a little bit about how that shows up for us. And then we work on skills. You know, I have to go talk to this doctor. I had a woman that I worked with. Her daughter had FAS. And before she would go into the room to see her daughter, she would speak with me for an hour because of the stigma and the bias that would show up when she went to visit her daughter. So I would spend an hour with her on the phone before she'd go in. She would go in to visit her daughter, and then it was an hour afterward so that she could decompress and talk about the way she felt and what she experienced in that space. And so we can also step in to advocate. I've been in the emergency room with that same client before. And so we get to do all of those wonderful things. Sarah? So what we've created is Operation Care by Hard Beauty. This actually was a response to listening to you, honestly. I'm now at 16 different hospitals in the state of Colorado, and I heard a lot of things. I heard, oh my gosh, those doctors and nurses aren't going to take care of us because they judge us, they have bias, they think I should pull it together. There was some negatives. Did I hear some of that? Sometimes, maybe a little bit, but what I actually heard more was that answer of, if I ask this mama if she needs support and the answer is yes, I really don't know what to do. And Angela talked about that at the beginning, right? And so I actually heard more of that than I heard of the other. I will acknowledge stigma and bias because it exists, but I really actually heard desperation and fear show up. And so we decided to create Operation Care. CARE stands for a compassionate acute response engagement. We're designed to meet the high acuity needs of pregnant persons experiencing the impact of SUD through connecting them with peer recovery support services. Peer coaches meet mamas where they're at. both in terms of willingness and at their bedside on either labor and delivery units or postpartum units. So basically, you know, Denver Health would call us, someone calls us, and within an hour to 2 hours, we actually can arrive bedside to a mama in need. I think the last week we have had 3 new births into the world. Bedside referrals are of moderate high acuity and require a quicker dispatch time. So this care side, we built a care slide that is like really for the acute side. And then we have a clinic side also that comes alongside that. But bed care services are generally shorter in term because we're not doing this isn't a funnel either. This isn't let me take mom and dad or mom and baby and have them funnel into our services. It really is an opportunity to provide an acute moment. We have access and we have coaches all over the state of Colorado. We also have access and know about coaching practices and other peer recovery communities all across the state of Colorado. Advocates for Recovery, Connect, Hornbuckle Foundation, Peer 180, Rise Up Recovery. I'm naming just a few, but our idea is that we can connect them to what is most important and closest to them. It's not just to us. If it makes sense that we would continue, we will do that, but that's not the idea. And we also know that change becomes more probable when basic needs are met. And so care coaches work closely with clients to understand their unique circumstances and what resources they could benefit from. For instance, we often arrive on labor and delivery spaces and mom has no clothes. She has no clean underwear. She has no nightgown. We have created an online Amazon registry right now where people are online donating gift cards and buying nightgowns and buying underwear and things like that. So we can create care bags so that we can show up with the things that moms may need in those acute moments. And you got to see one of my coaches in one of our we call them rosebuds, the little babies. Jamie is one of my coaches. Our moms are called daisies and our babies are called rosebuds. So we keep them daisy and buds. Right now, Operation Care has 7 coaches with a wealth of experience and skill who are also mamas in recovery. As we expand, we're looking to hire more peer recovery coaches to help the efforts, mainly because we have more hospitals signing on. We have 7 entities right now that have signed on to care. Of those 7 entities, we also take care of all of the women's clinics for Denver Health. So we have 14 clinics that attach to those 7 entities that we take care of right now. And we have them all the way from Grand Junction, Pueblo. We're taking care of Hugo, Colorado, and then we'll be expanding in the northeastern part of Colorado. So far, our OC is a unique one because out in the Eastern Plains in Hugo, there is no labor and delivery ward. Everybody gets served in the same hospital. So we kind of take care of that whole hospital. Currently, we have 39 OC clients across the 7 entities that we serve. This number does include Lincoln Health because we do take care of that entire hospital system there. But I will tell you 90% of that number belongs to moms in recovery that we work with. We have walked alongside I didn't change my bottom one, but 13 babies. We have taken care of 13 babies. And I love it because we have this beautiful little group chat that all of us coaches work in. I'm actually going to get to go do a delivery this week. 5 of our women, including myself, are doula trained as well, thanks to Elephant Circle. We were doula trained, and we go bedside to mamas in need. I have one that I'm going to get to deliver this week, which I'm really excited about in my community. And let me share with you that story too, why it's so important. This mother in my community really had struggled with substance use disorder for quite some time, and her daughter, same thing. We were going to do generational issues in small town living. Mom got sober first, daughter followed steps, but she had to go through her own journey. She's been incarcerated and struggled with an opiate use disorder. And she was very scared at first. She was like, I'm going to do this. I'm going to do this. I got this. And I said, look, I want you to know that if you're worried about walking into that space without somebody advocating for you, I just want you to know that I can do that. She's going to deliver this week, and it took her all the way to Friday to say, hey, Raquel, it's getting close. Now I'm scared, right? And I'm like, okay, that's okay. Like, we will do this within 5 days. You've got a delivery date. Like, sometimes it takes, and she's been in recovery, you guys, for over, I think she's got 3.5 years. She's having her first child. And here she is about to hit an hospital setting. And she reached out, and now she lives in my small community. I live in the town of Larkspur and Palmer Lake. I kind of consider myself more of a Palmer Laker. The population's only 2,500 in our community. She was going to be obviously more comfortable knowing somebody in her community that knew her mama and knew that to go and do this really big thing in her life. And I'm really honored that she would ask me to do that. And so that's kind of how it works in this community, right? Like, we trust each other as moms, and we can advocate in those spaces. Yeah, this is our team, and yeah, we're excited. We have we have 7 more hospitals that are interested in signing up for Operation Care. And then in that bottom left-hand corner, I added a QR code. That QR code is actually for our Discovery Recovery platform. Every single meeting on there is absolutely free. You do not have to be a client. You don't have to do anything. Like literally, and we have a Monday meeting, which is all for mamas, which is part of Tough as a Mother. It's kind of part of what Angela's got in that picture, which is a combination of what we did with Tough as a Mother. But we host a Monday meeting every Monday for women who are struggling with substance use disorders called Tougher Together with the state of Colorado. So, but every single meeting on that platform is free.
Thank you, Raquel and Angela. I will now pass it over to Rachel.
Yeah, and yeah, thanks both Raquel and Angela. And Raquel, I've loved doing those 16 site visits with you over the past year, girl. That has just been eye-opening, and that truly is where that service, like very unique mobile peer recovery service, came from. Is really nurses at the bedside that are like, I need help, you know?
Well, and the idea is we're actually creating a whole workforce, right? Like I'm guessing from other states, like Colorado is really leading that. I've been approached by 4 states to duplicate what we're doing to help in other areas, to train other women to do this work in other states. So Bravo, Moms Plus, CPCQC, and the state of Colorado, and all the L&D spaces. We're doing really good work here. I want you to know that.
And I think we just see peer as such a key piece here of so much of what Angela talked about that can really be a part of that warm handoff and conduit, right? And as folks go through those transitions of care. Just briefly here, we got to do several site visits, 5 in the past month here with our new round of sites. Moms Plus is really kind of the 2.0 version after SUD, right? So SUD is really all about universal screening and SBIRT and starting to look more into your data. And then for those hospitals that have really, leaned into that, Moms Plus can take that next step and really start doing things like, let's start treatment while you're here. Let's get plugged into community referral partners. Let's start bringing in peer support. So these are some of the site visits we were at. We're sending out some implementation plans. And I would say if you're on from one of our sites, please schedule your quarterly one-on-one call, because we have lots of great next 30, 60, 90-day goals for you to keep you on that path and keep that momentum that we all felt after each of those visits. So thank you for hosting us.
Thank you, Rachel. Yeah, those site visits were very eye-opening. So thank you all for hosting us as well. You've all seen this before, hopefully, but just to reiterate that we are working with Moms Plus and Chosen to really align these efforts. We know it's been sort of confusing in the hospitals as far as what programs you're in and how to work through some of these QI efforts. So we've really spent some time over the last few months collaborating and making sure we're all speaking the same language so that we can get some common messaging out to you guys as well. So we are hosting our final SBIRT training next Tuesday. This QR code, if you scan it, you can get registered. This is free for all of our participating hospitals. If you have staff that have not taken SBIRT training in the past, or if you have staff that haven't taken it recently, please send them to this 2-hour training. There are CEs attached to it. And then this is another announcement. Coming this summer, the University of Colorado is going to be hosting a free statewide perinatal psychiatric phone consultation line. We will send this as well in the follow-up email, but just to put this on all of your radars that this is coming soon. And this will also be a really great resource for you. So with that, we will thank you for attending. And if anybody has any last-minute questions for our speakers, feel free to come off mute or type them into the chat in our last couple minutes. And if not, we will see you during your one-on-one or our next Learning Collaborative call. Thanks, everyone.